welcome everybody back to the Endo Education Podcast. I'm your host, Nicole Notar, founder of Endo Excision for All. We're a nonprofit dedicated to ensuring equitable access to excision surgery and comprehensive endometriosis care. Today's episode is such an important conversation because we're diving into two areas that continue to shape the future of endometriosis care: that's specialized imaging and access to treatment. Joining me today is Dr. Miguel Luna Russo, gynecologic surgeon and endometriosis specialist at the Institute for Women's Health and Body, Complex Gynecology and Surgery. Dr. Luna Russo has focused much of his work on expanding endometriosis-specific imaging, improving diagnostic pathways, and increasing access to quality care for patients navigating the disease. Dr. Luna Russo, thank you so much for being here today.
Well, thank you guys for having me. This is something, I guess the topics are actually something that I'm very passionate about. I guess just diving in straight into who I am. I am originally from the Dominican Republic. That's where I was born and raised, and I did my medical school. And I came for training to the United States in OBGYN. I graduated from University of Mississippi Medical Center, and I did my fellowship in Cleveland Clinic, Ohio, where I stayed there for about, I was there for a total of about 5 years. I headed up the endometriosis center and chronic pelvic pain center at Cleveland Clinic. And I was also chief of GYN for one of the regional hospitals. I think my biggest passion for imaging started at Cleveland Clinic, but the reason I realized that I wanted to treat endo patients was, I always say this story, was one patient where came to the office, had multiple surgeries, and had her uterus removed. She was young. They were about to take her last remaining ovary out, and she had pain on one side. And I just realized that during my conversation with her that the pain wasn't really pelvic per se, it was more abdominal wall. And I noticed just by doing a physical exam, she had this little ball, and it ended up being like an endometriosis of the C-section scar.
Wow.
Yeah, and then I injected it, and then her pain went away, and she started crying, and I was like, wait, something's up. Like, I have to figure out what's going on. Like, all these women, and I started seeing more and more patients with endo, and I realized there's definitely need for good doctors in this space. So that's why I chose to kind of go the route that I took.
That's incredible. It's because you mentioned the C-section thing. That's how I was, or not I was diagnosed. My mom was diagnosed with endometriosis. I was born a C-section. And that's when they saw a tissue that didn't look normal, tested it, but thought nothing ever happened from it. This was 30 years ago. But that said, then when I started having my symptoms, my mom was like, I have something called endo. I wonder if this is what's going on with you. So then I was able to do my own research and figure it out. But that's so, just because you said the C-section thing, that reminded me of that story. That's I feel like there's always every surgeon I talk to specifically has some crazy story that brought them into this space.
Yeah, I think it's just that, you have to be a certain kind of, gynecologist to kind of want to be in this space, because it's a space where a lot of gynecologists are, I guess, not well trained in. So when they see, and even when I talk to residents and trainees, and when I teach residents and trainees, the biggest thing is the feedback I get sometimes is I don't know what to do, and that really just puts them in a difficult situation, and they're all of a sudden either afraid of the patient or afraid of the encounter, because it's just going to be, well, I don't know where this is going to take me. It's going to be a long conversation about pain and things that I don't really feel comfortable with. So I think it takes a breed of our, subspecialty or specialty to treat patients with endo.
Yeah, just that feeling of spending years chasing chasing answers. You don't even know what you're chasing in the beginning of it, right? Just searching and Googling and just being on this hunt to try to figure out what's wrong before coming across doctors like you who can actually help. But that brings me to what I really want to start unpacking now, is why diagnosing endometriosis is so difficult. As we all know, many patients still wait years before receiving a diagnosis. Why do you think these delays continue to happen despite our increased awareness in the past couple of years?
Well, I think there's a mix of things, but I think number one, it lies in the way that we teach obstetrics and gynecology as a specialty. I think we spend a lot of time when we're in residency doing obstetrics, and gynecology is there, but most of the time is focused. And once you're let out into the world, as a general OBGYN who's going to be taking care of women in all the spaces of their lives, pregnancy, pre-pregnancy, menopause, all these things. You have so much that you need to learn still. I personally don't think it's hard to diagnose endometriosis, but I'm a little biased. It's just really listening to the patient. I mean, it's really simple, honestly. If a patient has menstrual related pain, there's a very high likelihood that they have endo or adeno. So I think that's where we kind of have to put ourselves when we're seeing a patient with menstrual related pain. Is that this is where you are. I mean, there's only a couple of things that can cause this in women's health. So that's one side. I think the other part is the way that we traditionally looked at diagnosis, where we had to see the patient and then take the patient to the operating room, do a laparoscopy, and then figure out if they had endometriosis or not, and then either treat that incompletely or just make a diagnosis surgically, and then move on to the further aspects of treatment. I think that has created a diagnostic delay. People wanting to avoid that step of taking the patient to the OR and be afraid of what Pandora's box opens up as a provider, I think that delays. And then that's when people start getting birth control pills or Lupron or certain things to treat the symptoms of pain without actually arriving to a diagnosis.
When it comes to the diagnosis process too, in the patient community at least, there's so much debate around when a patient says, oh, I got diagnosed with endo from my ultrasound or my MRI, and then another patient's like, that's not true. I had a clear MRI, and then I had 70 lesions. That was my situation. I had a clear MRI, and I had 73 lesions. So how can you just like put an explanation to how some women can get a diagnostic off of imaging and why others don't?
Well, it's very dependent on there's several things. So it's very dependent on the imaging modality. So in order to have a good like ultrasound per se, endometriosis specific ultrasound should be the norm for the diagnosis, right? So it's not looking only at your ovaries and your uterus. It's looking at sliding signs, or your organs stuck, signs that give us kind of hints that this patient has endometriosis, right? Because you don't really particularly have to look at just lesions on imaging. You have to look at specific patterns or what we call hard and soft markers. Some women will not get diagnosed, I think, initially because they didn't have the right type of imaging and the person that was doing the imaging wasn't the right person to do the image or read the imaging. Also, we as endometriosis providers know that the absence of endometriosis on imaging does not really say or give the negative diagnosis of the disease. So that's when you start looking at clinical aspects of things, right? So you're not the patient has pain. There's no endometriosis lesions on imaging. That doesn't mean that there's no endo. So surgery would be the next step. But when surgery is the next step and you don't find it on imaging, you have to be prepared to actually treat the disease when you perform surgery on the patient.
Over the last, let's say, 5 years, how do you think the imaging has evolved?
I think imaging has evolved a lot in the last 5 years. I think we've gone. I mean, if you look at it honestly, ESHRE with it's a European Society of Human Reproductive Medicine. They said in 2022 that laparoscopy is no longer the gold standard. And we have gone into where it kind of overdrive. So 2022 until I guess now 2026, that ECOG has finally said that imaging is an adequate diagnostic tool for endometriosis. A lot has happened during that time. I think we've grown um, as I guess imagers or using imaging as a diagnostic tool. We've gone from implementing curriculums for MIGS fellowships, implementing curriculums for residencies in Canada and Europe on endometriosis specific ultrasounds. I think we are growing, and we're in these last 5 years we've gotten to, I guess, push that message out there enough where I think more and more patients are becoming imaging is becoming standard before you make a surgical procedure. It's a diagnostic tool. It's a preoperative imaging tool. It's preoperative diagnosis.
So is it, when you say standard, is it like a patient comes to you for a consult and it's just automatic, let's do ultrasound, let's do MRI? Or is it kind of depending on the severity of the symptoms that they're telling you and if you think you're going to operate?
Well, I mean, that's also very patient specific, but most of the time, I think 98% of the time, there's going to be advanced imaging in my practice. And I think when you talk to most of the surgeons that are in this area, you will see that they generally don't go to the OR without any imaging.
Are there any type of specific symptoms that you think are the most often overlooked? That like when a patient comes in, you're like, how did nobody flag this sooner?
I think that the urgency, the urinary symptoms, they are, I think they're super prominent, but in that, but patients, but they just get brushed off. It's either I have frequent UTIs, or they send the patient to a urologist and do 3 cystoscopies, and then they come into my office, for example, and we're like, well, I mean, this could be associated to endo. Has anybody asked you if you have painful cycles beyond those urinary symptoms? But I think urinary symptoms are probably the one that is brushed off the most in my experience.
That's that in my experience too. I had surgery 3 years ago, but the 2 years prior to surgery, I was getting a UTI every 3 months. So 4 times a year, lots of antibiotics, not fun. And then even the guy that I was dating, or even like the urgent cares, they every single time they'd be like, "This is often like you might want to check in with your partner and make sure you're not being cheated on. Like this is
Oh, imagine that.
like
Yeah.
those seeds in your head," which obviously didn't, was not good for my relationship. But I didn't realize that, and I said, I knew about endo at a young age because my mom was diagnosed with it. So I was doing like all the research and constantly in Google, and I just never saw any of that. And then so I viewed it as different from like my period issues and gastro issues. And then when I had surgery 3 years ago, I have had UTI since, and my bladder was covered in endo. So that's like that and another. Yeah, I'm very passionate on the bladder aspect for that reason, and I'm still with the same partner and have not have not had another UTI. So definitely prove them wrong. But yeah, that leads me to my other question too. Are there any specific types of endometriosis that could appear on imaging, like when you're looking for any organs that are moved around, or like is it more often to see bowel endo versus bladder endo when you're looking at imaging, if there were signs to appear?
So overall, for example, for MRI, in a general sense, right? So if you are in a community setting where you don't have like a massive imaging center like Cleveland Clinic or something like that, right? So those MRIs are going to be really good at picking up larger nodules. So when I counsel patients, this is arbitrary. Don't quote me on this, but like as in data, I tell them if anything's less than a centimeter, we won't be able to see it. Um, so MRI is really good at picking up ovarian endometriosis. It's good at picking up bowel endometriosis, bladder endometriosis, but it's better even at looking for endo and diagnosing endo in compartments. So anterior, that means in front of the uterus, the middle, which includes the uterus and the ovaries, and then the posterior compartment is where the bowel is. So that's generally the strong suit of MRI. It can give you some hints of what's adhered to what are the surgical planes look like. It's a very good planning tool for surgery. As for ultrasound is also excellent at ovarian endometriosis, and I think ultrasound is also great in the posterior, so behind the uterus when you have bowel, when you can see that the uterus is stuck to the rectum, etc.
So now the patient has the imaging, whether it shows anything or not, and then you decide to go get surgery. I can talk about this part for hours, but I'd love to hear from you. What do you think are the biggest barriers that patients are currently facing today in terms of access to care?
The lack of trained surgeons. And I think that the biggest barrier to that is that we tend to be in major metropolitan areas. Rural America doesn't have a whole lot of access to care. There's also like a decision paradox that happens when the patient goes online and they're trying to figure out who is the best surgeon for them, and who takes insurance and who doesn't take insurance, and does the doctor that takes insurance, are they better or worse than the ones that don't take insurance. I think that once you group all of those things, I think that's the biggest access. But for patient specific things, or patient specific situations, it's just that we are not enough in this country to take care of all of the patients that have endo. There's like what, 400, 500 of us ballpark, and there's 1 in 10 women in the United States with endo. It's rough.
Can you share just from the provider side of dealing with insurance and the limitations in terms of coverage? Like, and do you guys deal with the gap insurance, or is that like more the patient has to deal with that on their own?
So my particular practice, I take insurance. So I don't, there's no surgeon fees for my type of practice, the way that we designed it. So I don't particularly have to deal with insurance. I'm in a group where I just essentially, for example, I operate a specific hospital system, and because I did my surgery there, I said, look, this is the surgeries that I'm going to do, and this is for example, let's say the price per procedure that I want, and they do all of the insurance things. So I take all of the insurances. I don't. There's like maybe 2 insurance companies that I don't take.
Bless you.
No, thank you. I mean, I'll keep it up until I can. It's hard sometimes because it's it's like, I guess last Friday, not this past Friday, but the Friday before, like I was doing a very large surgery on a Friday afternoon, and it was like 7 hours, and I'm like, and sometimes you're like, well, I'm away from my family, and it's 7 hours, and the amount of money is not a massive amount of money. If you'd be surprised how much insurance will reimburse me for that, it's very minimal. And you would say, well, or even looking at thoracic endometriosis, and what we get paid for that it's not a lot. So it's not something I fault people for not taking insurance. It's just that me particularly, I have a specific, I guess, mission for the moment, if I can get it on, is that I want to allow access. So I mean, not having insurance, or or having health insurance, gives you access to surgeons like myself, who I'd like to say that I know what I'm doing, and helping patients, and I have to break the bank. So I think that the way that I've negotiated my reimbursement for the moment allows me to continue to take insurance.
That's incredible. I know that's what we're trying to fix in DC, is to get a separate code for excision, higher reimbursement rate, so that more of you can practice and network. I will tell you, in positive news, CMS hears us, and it's less of a fight now, and they agree that it's a no-brainer issue. Same with HHS. Now we're working with the AMA, and putting more pressure, working with Congress now to put pressure on CMS to make that decision. But I mean, obviously it's political speak, because let's sign some papers. Like, that's if you agree. So who knows how long this is going to take. But it definitely has shifted. And when we first started this about 2 years ago, it was just like persistence of trying to present the data and make, this is why excision needs a higher reimbursement rate. It's a completely different surgical method than ablation. It needs to be recognized as such. And now it's less fighting and more, okay, who are the right people we need to talk to that can actually do this? So we're making headway, but it's definitely, I don't know, it is a no-brainer. I just don't understand how it even got here.
You have to take money from something else to give it to this, to this. It's just, it's the politics of healthcare and reimbursement. It's it is what it is, and I think it'll change, and because of patient advocacy and physician advocacy, and hopefully ACOG will tag along, and all of these things, we'll get there. But the more time passes, the more patients suffer, just because it's not equitable. So it's important to create access. Like even in major cities, you have hubs, right? And then you have the academic group, and then the academic group is trying to take care of as many patients as they can, for example. But then you have the private groups that are taking care of patients as well, but the access is limited to some, even with, you know, endosurgery for all. It's just, it's, you have ways, you're trying to get access to patients, but I think the basic barrier is there's a limited group of people. You don't get really paid enough by the government or insurance companies for the surgeries that you do, for the amount of surgery and the complex care. So there's going to be disparity.
And then on the patient side, just say how exhausting it is to constantly fight to be believed, fight for referrals, fight for coverage when you're already living in pain, or have to do self-pay, like depending on where you are. What do you think providers in the healthcare system still misunderstand about the patient experience through all this?
Wow, that's a hard question. I think that what they misunderstand is that they don't really see that there's the person that's sitting in front of them is actually just trying to advocate for their own health in the best way possible. Sometimes that may not come off as that, but understanding that from the get-go, I think relieves a lot of the tension and creates help. It creates an environment where you want to help the person, right? So I think that that's the biggest thing. When a patient comes in with a stack of papers this big, 5 op notes and 20 pictures and 50 ultrasounds, and that doctor has 15 to 30 minutes to take it, it's hard. It's, I think that that's the number one. I think that's the number one thing that we're missing is that when somebody comes in with that stack of papers, it's like maybe you just take a step back and take a look at it and say, something's wrong. This person's not making this up. There's no way. There's no way there's 1 in 10 women with that are hypochondriacs or Munchausen's. There's no way. You know what I mean? So I think taking a step back and saying, well, if I don't feel comfortable doing this, then let me figure out where I can send this patient where she's going to be heard and diagnosed correctly and treated correctly.
When it comes, like you say, walking in as a patient, you're walking with that stack of paperwork, and you've already maybe been burned a couple times by other providers. What would you say are some red flags, green flags that patients should keep in mind when they're going into an appointment with an endo specialist to know if they're in the right place?
I don't know if we can do red flags or green flags. I think it's important to. I think the first thing is, do you feel comfortable with that person? And I think you can. I think you can figure that out most of the time when somebody walks in the room, and you're kind of like, what are the first parts of the conversation?
Yeah.
If the conversation directly goes on, that person sits down and tells you, listens to maybe 2 sentences and says, well, I don't think you need surgery. Or I think you probably need to stay on this birth control. Like, there's I think that's a super red flag. If you sit down with that doctor and that doctor's like, well, thanks for bringing all of this. I took a look, tells you 2 or 3 things of the things that are in the packet, and be like, so tell me your story. Like, what's going on? I think that's a green flag. I think that's just when you start noticing that person is actually wanting to help you and has looked through everything.
Yeah.
Yeah, just listen. So I think in summary, listening. If somebody listens to you, then that's a good person. Overall, I mean, surgical skill is a different way to evaluate that, but I think that the first step is having somebody that's actually listening and is accepting that you're coming in with a problem that's going to help you.
And for what you're saying with that, when you're coming in and you're being listened to finally, and so many of us are told for years that our imaging is normal or our labs are normal and everything's normal, and then finding that doctor is like, all right, let's dive into this deeper. This is clearly something's wrong. If you're in pain, you're sitting here, like you don't want to be here for fun. But if you could define what normal imaging actually is, because that was something I found the most frustrating, is all the ER visits I had as a kid, as a teenager, and young adult life. And I had free fluid cysts that came and went every month, or cyclical cysts. And when I found the same imaging, when I finally went to found an endo specialist, they're like, those aren't free fluid, those are endometriomas. That's not normal imaging at all whatsoever. So it was the same imaging, wasn't no new images, but just how different providers are reading it. So if you could define too, like what is normal imaging?
There is the normal image, a normal scan. I don't want to say, we don't even call it normal scan. We call it negative. We call it negative scan. Negative for findings suggestive of endometriosis, or negative for findings suggestive of adenomyosis. I think it's and when we're looking at normal imaging, it's just whatever the report says, right? So the radiology reads it, and then it's just that the report is negative.
Yeah.
But then when you open up the image, you see images that are consistent with an endometrioma, that it's ground glass appearance of the ovary, of the ovarian cyst, and it's a cyst that's been there constantly on the same side for multiple imaging, multiple imaging rounds. So I don't particularly like the term normal, and negative. It's just, I guess, if you want to say what a negative image is like there's no soft markers for endometriosis. There's no organs stuck to each other. There's no thickening of the uterosacral ligaments. There's no evidence of adenomyosis. Just with the evidence of adenomyosis, 80% of those patients will have endometriosis, even if you don't see it on the image. That your ovaries look normal, that there are no hemorrhagic looking cysts on the ovaries or endometriosis looking cysts, no hydrosalpinx. That's what you're looking for, as in like hard markers and soft markers. So that would be like the absence of all of the things that I just mentioned is probably a normal image.
Going off of that too, what do you think is the biggest myth about endometriosis out there on the provider or patient side?
Biggest myth, honestly, that women of color do not get endo. I mean, there's a published paper even on this in fertility and sterility. I think that women of color get it, and they get it probably worse than most.
Yeah.
It's not, and I think there's other things that obese patients also don't have severe endometriosis or don't get as severe endometriosis, and I think that that's also not true. So I think those are to me the biggest ones that stand out.
Geez, I didn't even know that one. That's absolutely ridiculous. When it comes to one thing that you wish, and just in terms of pelvic pain in general, what's one thing you think could be a delay in terms of providers understanding pelvic pain in general? Does depend like on what's normal, what's not normal. Okay, you get some like what's they call a middle schmerz, like the pain during ovulation that bounces between each side. Like, oh, that's totally normal. It's like typical pelvic pain. We don't need to dive into that further. Like things like that you wish other providers understood that needs to be taken seriously, maybe referred to an endo specialist or anything else in the pelvic pain area, not necessarily even.
Yeah, I think that the biggest thing that I see that leads to delayed diagnosis, that I think is a super red flag, and I tell it to patients, is that patients come in and they're like, my ovaries hurt, and it's like, really, I don't. It's hard to explain. It's not your ovaries, right? So, and then, but I went to the emergency room when I was in a lot of pain, and I had a cyst, and it was a cyst that burst, and it was a cyst, and then when you do a scan, then that cyst is not there. What people are not understanding is that patient is reacting, is having exacerbations during the mid-cycle portion. So mid-cycle, right after ovulation, right when you have a heightened, you have elevation of prostaglandins, and your pelvic floor dysfunction can get worse during that time. So most of these patients are going in asking for help to the emergency room with significant pain mid-cycle when they're just about to ovulate or right after they ovulate, and then they do a scan and they're like, oh, it's your cyst. And then when they show up to the office and to have a follow-up appointment, that cyst is no longer there.
Yeah.
So now we're blaming ovarian cysts that are supposed to be there every month. You're supposed to ovulate every month. I'm talking about just follicular cysts. I'm not talking about hemorrhagics or abnormal cysts. And then this patient is blaming everything on her ovaries, and it's not. There's something that is causing this pelvic pain flare up or this pelvic pain exacerbation during that specific cycle time. I think that's my biggest, I guess you can call it pet peeve, but I see that a lot in the office, and it's very frustrating because it's not, I mean, this patient's coming in 3 times and they're telling you, hey, it's menstrual related pain that's severe enough to take him to the emergency room, and you're like, oh, you just had a cyst burst. No, that needs to be studied a little better. Get an MRI, do a pelvic exam. Let's see, get a menstrual history. I think that if you, when you do that menstrual history 9 out of 10 times, that patient is going to have suggestive history of endometriosis.
I was just gonna say, could you have cysts that hemorrhage if you don't have endometriosis, like other causes?
There are hemorrhagic corpus luteum cysts. So those are hemorrhagic cysts that fill up with blood. It's a product of ovulation. Those are often, there can be confused with blood, but those are generally cause acute abdominal pain and can cause hemoperitoneum or blood in the peritoneal cavity. Those are very different to endo. They don't really look the same. They
Yeah.
can be confused in some aspect, sometimes as well.
Well, talking about that cyst can burst and then you end up in the ER. I think part of too with being dismissed for so long and going to a doctor, going to the ER, and then being sent home, and having everything played as no big deal. What are some symptoms that patients should never ignore? Because that's something that I see in the patient community all the time, is like waiting till you're basically feeling you're on death's door to go to the hospital because you've dealt with so much pain before. Like the red flag symptoms, whether it's like you have a fever, or your abdominal pain is so bad you're vomiting, like things that patient need to say, okay, I need to go
Not
house.
None of the things that you just all of the things that you just mentioned.
Everything.
Yes, I mean, I think that the biggest thing, and I tell this to, and even when I like go out and talk and teach and talk to GYNs, I said, if they're sitting in your office and telling you they're missing school and they have nausea and vomiting associated to their menstrual cycle, or they have pain that is present throughout the whole month in their pelvis, these patients need to be seen by, or studied for endometriosis, seeking a diagnosis. And if you don't have the ability to do that, send them somewhere else. I say this a lot, and is that physiologic processes should not hurt. It should not hurt you to breathe. It should not hurt you to think. It should not hurt you to blink. Menstruation is physiologic. It should not put you down every month. It's just not the way that a normal menstruation works.
Yeah.
So painful periods, period. Let's figure out what that's about, because it's not normal.
Obviously a lot of work to do, but I'd like to talk a little bit about where you see the future of endometriosis care heading. Is there anything that gives you hope about the future of endometriosis care right now?
Yeah, so I think that we're heading in the right direction. I think that in the last probably 10 years, we've grown in moving towards a clinical diagnosis. We're training more surgeons. I do believe that we don't have enough access, but I think that access points are coming up. I think that with the new ICD-10 codes that came out a couple years ago, plus the advocacy that's going on towards improving reimbursement, is going to bring more money into this field, and and research funding is going to grow, and the access to the patients is going to grow. I in the next 10 years, I am hoping to see that minimally invasive or actually now complex benign gynecology becomes a subspecialty, and within that subspecialty, you're going to have more surgeons that can take care, more gynecologists that can take care of endo patients. I think looking at the other question with regards to, I guess, was it hope or was it
Hope.
Hope. Well, I hope that patients don't tire, because I think that I'm a big fan of patient advocates. I think that they move the needle significantly for this disease process to kind of wake up and stir up the pot enough. Not stirring up is like you're like this. I'm in pain. I need help, but stirring everything up, bringing it up to the surface where people are paying attention, and that helps us as doctors, right? Because we want people to pay attention to this disease process so that it makes it easier for us to kind of to treat, to have more access to be able to treat all these patients. But we also have to be careful about what comes with that, right? Because there's a lot of attention that's coming into the endometriosis space, right? So the biggest attention that you have now is there is money to be made, and we have to make sure that we keep the patients in mind and do the right thing, and that people with deep pockets don't try to profit off of the suffering of many women. So I hope that doesn't happen, but I think that patient advocates, they're hard. I don't think they'll let that slide. And we're right there with them. It's just that we're less.
You're doing the dirty work. You're like really in
Yeah.
there. You're getting rid of it. You're excising it. Because you brought it up a few times, in the most important way, the lack of qualified specialists, the lack of numbers of qualified specialists. What is that process of becoming is there a fellowship or advanced training after med school, or is it part of med school? Like how do you become a specialist in endo?
So you have to go through med school, then you have to do your residency in OBGYN. That's 4 years. Then you would need to do an advanced GYN surgery fellowship. That either is GYN oncology, which there's not a lot of GYN oncologists that take good care of endo patients, or complex benign gynecology or mixed. So that's another 2 to 3 years. And even in that group of the complex benign gynecology or advanced surgical gynecologists, depends on where you go and where you train, right? There are programs that are not endometriosis heavy. There are programs that are endometriosis heavy. For those who are not endometriosis heavy, then you would go and find a endometriosis heavy place and do an extra year. I know that CEC in Atlanta has a fellowship for endo. That kind of stuff you can do. But if you go to a program, endo heavy programs, you generally don't need that, but that takes that long. So it's 4 years plus 2 to 3 plus 1. So there you go. It's a lot.
Long time.
Yeah.
Very long time. Um, to go back to the conversation before, we're talking about hope for the future. Are there any advancements in imaging and diagnostics that you're excited about? Because there's a lot of noise around like blood tests and this imaging test and this pelvic MRI coil and like all these different things. Is there anything that you're the most excited about when it comes to imaging and diagnostics?
I am very much excited about AI for imaging and diagnostics.
Yeah.
I think that it's not going to replace our radiologist ever. But it can be a massive tool, specifically for surgeons and doctors in a community setting where you don't have like this person who did a fellowship in MRI fellowship and or body imaging fellowship and can read all of the endo scans. Like I think AI is going to help those doctors for example, in a community setting who are like reading chest X-rays from the emergency room, from the ICU, and then they roll an MRI of the pelvis or for the endometriosis protocol rolls through there. I think AI will help them diagnose things and be a little bit more accurate.
That is exciting. That's something with Wendy Van Buren we just teamed up with to do an initiative on the policy side. We just had a heavy conversation about imaging and the protocols, and especially with bowel endometriosis. And she has all these ideas, and we're like, this is amazing. Like, what can we do as patients? Like, we have more time than you guys. So what can we do on the policy side to like get this lifted? Like, you guys have the data, you guys have the experience, you have all the information, just feed it to us so that we can make action items. So we just started literally like 3 weeks ago, started that initiative. So excited to see what comes from that. But really, like what you were saying before, just about like education and how we can improve the education and make that like a didactic of, okay, you need to learn how to read these images for endometriosis and adenomyosis. I was just at a community event that an endo specialist from up here is at, and he's showing these ultrasounds and showing the adenomyosis on the ultrasounds. And I'm like, you're pointing it out to me, like I can see it. So how come, I mean, obviously pointing it out, I would have no idea what I'm looking at, but like, it's still clear as day. Like there's like, I mean, I know there has to be a lot of education around it, but just the fact that that's not already being done, like why can't it just, I mean, I know it's way more complicated than it is in my head.
Yeah, you just have to dissect the way that radiologists get educated and the way that we as GYNs get educated, right? So I think that gets and actually putting importance in women's health. Like I studied for example, I studied in the Dominican Republic medicine. That's where I'm from. We had a whole 3 month part of our medical school was being a sub-I, an intern in a maternity, like in OBGYN, like delivering babies and GYN. And that's because that country decided that because they had a high maternal mortality rate, that they needed to teach their doctors women's health. So we got taught women's health very well. But in medical schools in the United States, it's 3 weeks at the most. And then what do you think? How do you think that dissipates into non-OBGYN specialties? General surgery, urology, radiology. There's only a finite amount of women's health stuff that is being, or issues that is being taught in those residency programs. So I think that amplifying the fact that, hey, this is important and let's teach more of it is number one. And then number two, we need money for research and to educate these people as well.
Well, and like you just hit the nail on the head with talking about all the other the subspecialties and just the multidisciplinary collaboration that we need to improve these outcomes, and just bringing together like the urologist, the gastroenterologist. That's something that drives me crazy. That in my personal journey, my gastro symptoms were the daily occurrence. My periods were horrific, but at least I knew it was like 3 days out of the month. My gastro symptoms were the ones every day that really impacted my life severely. So nothing out of all the doctors I went to, like my parents took me everywhere. Nobody drew the line of like, okay, really bad menstrual cramps and menstrual symptoms. Family history of endometriosis. Like I told you, my mom has endometriosis. My grandmother, like her mom, had endometriosis. It's also on my dad's side. My aunt has it, and my grandmother had it, and they're both passed out. But I'm like, I was born to have this disease. So how did they not connect the dots with the gastro symptoms and that family history, and then the menstrual symptoms as well? Because also very
Yeah, but how many times did you go to the gastroenterologist and the gastroenterologist asked you about your menstrual history?
Never,
Ah, see?
never.
So it's hard. Even the PCPs, the primary care, sometimes they don't even ask you that. So there's no way to catch it on the front end if they don't know to ask, and if it's not important. And it's a public health issue. Like these processes is a public health issue. Like it's an epidemic essentially, in my opinion. But I think that that's the important thing is like we don't teach it. We don't teach GIs to ask menstrual history. I mean, granted, I came to this community and there was no endometriosis, care in Palm Beach County or in St. Lucie County, which is, north of us. And there was nothing from Weston, where Cleveland Clinic is, to all the way up to Orlando or Tampa. Just having me present here, like I've gotten referrals. I started working with GIs and I started, sending referrals out and talking to them. Now they're like, oh, this patient may have endo because they get IBS symptoms during their menstrual cycle.
Is what I call
Yeah.
it.
So like I get referrals from pediatricians that are like, well, this 16-year-old has debilitating pelvic pain during her menstrual cycle. Like you just have to put somebody in a community that wants to educate, number one, and then do that job and drive to change. But that takes a significant amount of effort and time, and not everybody wants to do it.
Yeah.
But I think education and bringing it up to light is the most important thing.
Before we wrap up, I want to end on more of an encouraging note for the listeners who are struggling to find answers, support, and proper care. So I always ask the same question to every provider is, what's one piece of advice that you would give to the 15-year-old, 20-year-old, 30-year-old, 40-year-old, doesn't matter the age, but that's sitting in their doctor's office, leaving with no answers, and just really in the grid of this journey?
My biggest thing is don't give up, and you are right and they're not. That's the biggest thing. Patients know when something's wrong,
You know
and
your body.
yeah, you're gonna be right most of the time. So don't take no for an answer. Find somebody that can advocate for you and keep advocating for yourself. That's what I would say.
That's great advice. And then for anybody who is in Palm Beach County or St. Lucie County, where can patients who want to see you find you and follow your work and make an appointment with you, learn more about your work?
Yeah, so I mean, if you Google my name, Dr. Miguel Luna Russo, it'll come back up. I have an office in West Palm Beach, and also seeing patients out of off the office in Wellington. So if you Google Institute for Women's Health and Body and my name, Miguel Luna Russo, Dr. Miguel Luna Russo, you'll find my little Google page, and that has the phone number and the addresses for the for that. Or you can follow me on Instagram. It's Dr. Luna GYN. Um, and if you shoot me a direct like a message, the information about the office will pop up.
Awesome. Well, thank you. Thank you so much for this conversation. And everybody else, thank you for listening.